Hello all, I welcome you for this Fastrack session to another video. Now we are going to see one of the important topic, that is contraception, where it is also important in community health nursing as well as in gynecology. Okay, now we are going to discuss about this contraception in a complete basis and related MCQs. Okay, yes. So contraception in the sense, what does it tell? Contraception, where it prevents or stops pregnancy. Right. Always we are having two methods. We all know that is temporary and permanent method. Contraception. So in temporary we are having physical barrier, hormonal barrier, and this thing called hormonal contraceptives we'll be having. Coming on to the permanent method, in male it is vasectomy, in female it is tubectomy. Tubal ligation we are going to do. Okay, coming on to this methods, we are having natural methods also. So what does this tells? Okay, in the natural method we are having the rhythmic method. Rhythmic, that is the calendar method. So which is the safest time to have intercourse for a couple you are counseling? So first thing is after menstruation. After menstruation, in the sense, consider a woman will be bleeding 1 to 6 days or 1 to 7 days. After that, maximum 5 days they will be bleeding. After that, first 7 days. First 7 days in the sense 6, 7, 8, 9, 10, 11. So till 11th day, it is possible they can have intercourse, but the two will not be less chances to get pregnant also. Okay, another thing is after the luteal phase, in the secretory phase they can have, that is before menstruation 7 days. Before menstruation 7 days. Okay, where the secretory phase is taking place. We all know that first during the menstruation, first is menstruation phase where the bloods will be there, and second thing is pre-ovulatory phase. Pre-ovulatory phase, in that what is happening exactly? Follicular development, follicular phase, and proliferation is happening. Proliferation is happening. In third, ovulation is happening. Fourth, we'll be telling luteal phase, and secretory phase is happening. Okay, and endometrial sheds. Endometrial will get sheds. Okay, this is the normal physiology happening. So what is this natural method? Is calendar method we can say. Okay, basal body temperature. Okay, basal body temperature method. Okay, then cervical mucus method. Cervical mucus method in the sense, what about this basal body temperature? Basal body temperature in the mid luteal phase, there will be increased amount of temperature will be there. But if there is low body temperature, that time also we can do, but this is not recommended. Okay, it's not recommended. Coming on to this cervical mucus thing. So this is a natural method. 1 to 6 days it will be dry and sticky, and 7 to 9 days it is creamy, where it is not fertile. If it is fertile, wet and clear 10 to 12 days, that time it is not recommended. And egg white 13 to 14 days you should not have intercourse. That's what this cervical mucus thing. Coming on to the next thing, what is this cyclobeds Tirumala method, which is used by the illiterate woman? This is your MCQ point where you can focus. Okay, cyclobeds is the thing where they will be having a thing called a ring like method, a band like method, where there will be having a rubber elastic band. They will be keep on moving day by day. So then we can able to identify which time they can have intercourse to avoid pregnancy, which time they can have to fertile the pregnancy. So this is how the method works. You just remember the name called cyclobed Tirumala method is followed by which type of woman, illiterate woman or not illiterate woman. Okay, that question can be asked. Okay, it's a very simple method. Coming on to the barrier method. So barrier method also we can say physical method. Okay, male condoms, we all know it comes under also National Family Planning Program. One time use. Okay, female condoms will be having 2 rings, that is reusable up to 2 twice, distributed to female sex workers also. This female condoms FC2, and diaphragm, that is also wash and reusable thing for 1 year. And coming on to the today's sponge, it contains 1 gram nonoxyl 9, that is the spermicide. Germicide also we can say germicide. Spermicide, so it is reusable for 24 hours, where the chemical components is present. Okay. Now we are having hormonal and non-hormonal method. Now just we will see the overview and we will be discussing in detail. Okay. Coming on to the hormonal method, where we'll be having a contraceptive pill which is combination of estrogen and progesterone. Coming on to the non-hormonal method, natural cycles, already I have told in the natural methods. Coming on to the OR ring, which is also a hormonal method, and male condoms, which is having of 93% of avoiding pregnancy. Here also 93%, but 87% only in condoms. So which is more effective? That is hormonal IUCD and copper T. Okay, copper based IUD, that is copper 380A. Okay, 380A, we all came to know that. Okay, yes, this is how. Now we are going to discuss about the hormonal contraceptives. Okay, type, we are going to see the types as well as the defects and the dose, everything we are going to discuss. Combined OCP, that is OCP is the term called oral combined pills, not contraceptive pills, oral combined pills. Okay, it inhibits ovulation. Obviously it will reduce the FSH and LH. If there is a negative feedback towards that, there won't be ovulation going to take place. It will not trigger the estrogen too. Okay, it thickens the cervical mucus and thins the endometrium, so where endometrial sheds is going to happen. Okay, and 1 pill per day for 21 days, that is the major thing you have to note. 1 day per pill for 21 days, and 7-day gap iron pills also should be taken, because the blood loss is there. They should take iron tablets too, and taken cyclic every month. Every month they should take if they are planning for this OCP. And POP, progesterone only pills, that is Cerazide, thickens cervical mucus, where ovulation may occur. Low dose progesterone is given. Okay, ovulation may occur in this pill. Okay, 1 pill daily continuously, no pill free days. They should take continuously 1 pill per day, and it is a continuous use. Coming on to this DMPA, that is Anthra, inhibits ovulation, where it delays the fertility return and decreases the bone mineral density. Also irregular bleeding is also possible. Anthra, and 150 mg IM injection every 3 months to prevent the pregnancy, 3 months per injection. Okay, we are going to give. Coming on to the implants, that is Norplant, we will say it inhibits the ovulation. The only thing is it inhibits the ovulation. So it is a long active reversible contraception where subdermal rods, usually 1 or 2 rods, it is duration is maximum 3 to 5 years. It can be there's a Norplant 3 to 5 years. That is your MCQ point. You can note Norplant. What is the duration of maximum? That is 3 to 5 years. Antra will have what is the dosage? That is your MCQ here. And it is for every 3 months. 3 months once. Okay. Yes. Coming on to this hormonal contraceptives indications. Whom and all we are going to give. Okay. Now we are going to discuss about hormonal contraceptives indications. Indications, how to whom and all we are going to prescribe this oral contraceptive, that is hormonal contraceptives. Coming on to this OCPs, OCPs will have a higher risk of this breast cancer. Okay, so we should not prescribe any. If there is an history of breast cancer, then we are not going to prescribe this OCPs. Okay, it is a regular contraception in the healthy human. Irregular cycles, we will have this estrogen progesterone. Primary dysmenorrhea, obviously we are going to give. Mild endometriosis, is there any acne, hysterism, PCOS, then we are going to give. Decreased menstrual loss, that is abnormal uterine bleeding, any fibroids, any adenomyosis. In adenomyosis, I have told what sign will be seen in ultrasound. Come on, tell me. Which is the most common dangerous thing in fibroids? Dangerous type. Come on. In adenomyosis, yes, it is Cogwell sign. Cogwell sign. Coming on to fibroids, that is subserosal. Okay, yes. Coming on to this post, that is menopausal woman. Post menopausal symptoms is there. Obviously, there will be decreased estrogen and progesterone. So that we are going to give to, if the, what is the most common symptom in menopause? That is always hot flushes, dry vagina, senile vaginitis, we can say. For that, this selective serotonin reuptake inhibitor with, we are going to give this. Okay, with OCPs we are going to give that to manage the symptoms of postmenopausal thing which is happening for the woman. Okay, yes. Coming on to the progesterone only pill, that is Cerazide. For the lactating woman, for safe puerperium postpartum, up to 6 weeks, more than 6 weeks we are going to give. Not less than 6 weeks we are going to give. Okay. Woman with contraindication, 6 weeks also, 4 weeks also we can give. Equal to 4 weeks or greater than 4 weeks we can give. Okay, coming on to the contraindication to estrogen, example migraine with aura, smoker, we are going to give only this. Patient at high risk of thrombosis, we are not going to give this estrogen with progesterone only pills we are going to give. Coming on to this DMPA, that is Antra, long term, it is a long term contraception. Obviously, woman cannot use estrogen, we can give. What it is, it decreases the seizure activity. If the woman is having sickle cell anemia, then we are going to give, which will reduce the sickle episodes. Sickle cell crisis, you all know that, right? Sickle cell crisis. Okay, where pain will be high. And adolescent needs infrequent dosing. Yes, breastfeeding woman greater than 4 weeks and postpartum. Here, this POP can be given only at 6 weeks or 4 weeks, but this Antra we can give equal to 4 weeks or greater than 4 weeks. Okay, yes. Coming on to the implants, that is Norplant, long term reversible contraception we are going to use. Okay, long term reversible contraception, that is 3 to 5 years. Okay, woman wanting delay in pregnancy, if they want a delay in pregnancy, they can use this Norplant. Estrogen If the estrogen is contraindicated, like cardiovascular risk, any history of cancer, any liver disease is there, then we are going to give this Norplant. In adolescents or poor pill compliance, then we are going to use this Norplant. I hope you have understood. Only thing you have to notice, this progesterone only pill we can use 6 weeks. If the option is 4, you can choose only 6 weeks or more than 6 weeks. If there is only 4 not 6, then you should choose only 6. Okay, 4 is there, then choose only 4. Okay, 4 and 6 are there, then choose only 6. Okay, more than 6 weeks it is indicated. Coming on to this Anthra, if 4 and 6 are there in the option, choose 4 not 6. Okay, had the clarity? I will explain you again so that you may have the clarity. Okay, for this progesterone only pills, if there is in the option, if they are asking a question for which woman, in a postpartum woman, for how many weeks more than we can give this progesterone only pills, is there any question like that? You have to choose. If the options are 4, 6, 8, you have to choose 6, more than 6 or more than 6. If the option only 4, 7, 9, 10, then you have to choose 4. Okay, for progesterone only contraceptive. When coming on to this Anthra, it is very easy. If there is a question, Anthra is indicated for postpartum woman, how many duration of which weeks? If they are asking any question, if the options are 4, 6, 8, 10, in that you have to choose 4 not 6. Okay, greater than 4 weeks Anthra is indicated. Don't bother about 6 weeks. Only you should bother about this POP, progesterone only contraceptive pill. If there is a option 6, go for 6. Okay, yes. Coming on to this intrauterine contraceptive device. Okay, we are going to do the summary. Okay, coming on to the generation, we are having 3 generations. Now we are using which generation? That is also maybe a question. Which generation is copper 380A? Whether it is second, first, fourth, so on. Then you will be making a mistake. So that only I have made this also. Okay. First generation is always Lippis loop, where it is a plastic, inert plastic. So now we are not using this. Okay. High failure rate is there. So we are not using. Due to that failure rate, we are not using in the day-to-day aspect. Okay. Coming on to this, it is absolute for 3 to 5 years. It will reduce its lifetime. Okay, not 5 years. After 5 years, it reduces. And coming on to the second generation, now we are using this copper 200 and copper T380A. Copper T200 and copper T380A, where copper, it is copper containing. Copper induces inflammation and sperm toxicity. Okay, so that we are using this. Copper 200, this is your MCQ point. Copper 200 is 3 years and copper 380 is 10 years. 380A is 10 years. Most widely used and also as emergency contraception. This you should make a point. Coming on to this multi-load. So multi-load have this copper intrauterine with flexible arms. There will be a flexible arms where same as copper T. Where this ML250 as 3 years, multi-load 375 as 5 years. This is your MCQ point. ML250 is 3 years. Okay, then ML375 is 5 years. Copper 380A is 10 years. Okay, without saying you should tell. Okay, come on, next. Third generation, this comes here, Mirena. We will be calling it as LNG, levonorgestrel IUCD, where hormone release of levonorgestrel 2 microgram per day. It inhibits implantation and thickens the cervical mucus. What is the duration is? Maximum of 5 years. So Mirena is used in abnormal uterine bleeding, where it due to this thickening it will be reducing the symptom, and where endometriosis will be reducing PID also it will reduce and decreases the bleeding. Okay, these are the important things you should note in third generation, that is Mirena. Okay, yes. Coming on to this contraindication, IUCD is contraindicated in undiagnosed vaginal bleeding. If that bleeding is not diagnosed, whether we cannot expect it is idiopathic or any other thing, the bleeding is happening without diagnosis, then we should not use this IUCD. We have to confirm what is the bleeding and how the bleeding is happening, where what is the condition is taking place for the woman, then only we should implement this IUCD program. Okay, or else it is not indicated. Disordered uterine cavity, yes. Pelvic inflammatory disease is suspected, then we should not use this IUCD. Suspected pregnancy, we should not use this IUCD. Okay. Mirena, what is the contraindication? Mirena, CA breast, liver disease, active liver disease is there, we should not use this IUCD. Okay, yes. And specific contraindication, copper T alone is Wilson disease, because what is Wilson disease? Wilson disease is the copper accumulation, copper toxicity, abnormal accumulation of copper in the body, so that further administering this Wilson, further administering this copper T, it will cause increase in copper, where it may worsen the patient's symptoms. Okay, Wilson disease, you should make a note. Okay, specific contraindication only for copper T alone. Okay, coming on to the emergency contraception. Here comes the point. Emergency contraception, you will be having a question definitely. Okay, coming on to the levonorgestrel, it delays ovulation within 72 hours. They should take within 72 hours of unprotected sex. Okay, yes. Coming on to this, it is having 1.5 mg stat, most common, and it's also included in National Family Planning Program. This point you should note. Okay, coming on to this ulipristal acetate, where it delays the ovulation, most effective hormonal contraceptive, emergency contraceptive. Most effective is this one, this ulipristal. Okay, what is the dosage is 30 mg stat. Coming on to this mifepristol, it inhibits implantation. Here this levonorgestrel and ulipristal will delay ovulation, but this mifepristone will inhibit the implantation. Okay, what is the dosage is 10 to 50 mg. Coming on to this UZP method, where it is having estrogen plus progesterone 2+2 pills, but it is less used. So already we are using it as oral combined pills, but somehow we have used this in emergency contraceptive pill, but it is not that much effective, so we are not using it now, but it comes under the category of this emergency contraceptive pills. Okay, copper 380A, already I have told, copper 380A is used as an emergency contraceptive thing. Okay, prevents fertilization within 5 days, and it is the most effective of overall, is the most effective. Coming on to this drug, then we can say this, what the thing, ulipristal is the most effective hormonal contraceptive pill. Coming on to the most effective emergency contraceptive, then we have to choose this copper T380A. Can you feel the difference? If the most effective hormonal emergency contraceptive pill, then we can choose this ulipristal. What is the most effective contraceptive for emergency situation? Then we have to choose copper 380A. No, not hormonal method is okay. Then which is not considered as the emergency contraceptive? Then we have to choose this. What are the things? Progesterone only contraceptive pill, Mirena and misoprostol. They are not considered as emergency contraceptive pills, emergency contraceptions. Okay. Coming on to the postpartum contraception. So rule of 3 we are following. So which time we are going to start? Feeding type and when to start this oral combined pills. Exclusive breastfeeding after 6 weeks, ideal is 6 months. 6 weeks or more than 6 weeks. Coming on to the non or partial breastfeeding woman, then within 3 weeks we can start, but ideal is always 6 weeks. Here 6 months, it is 6 weeks here. Okay. Coming on to this DMPA, already that is Anthra. Okay. Depot medroxyprogesterone acetate. On non-breastfeeding, we can start day 1 itself. If breastfeeding, already I have told, greater than 4 weeks. Okay. IUCD timing for post-menopausal postpartum interval. So within 10 minutes of delivery, post-placentally it is post-placental thing. Then after third stage of labor, then we can within 10 minutes we can administer this IUCD. If postpartum up to 48 hours, maximum after 6 hours we can use this IUCD. Okay. Coming on to this permanent method. Here tubectomy in the postpartum mini lab we are using, that is 24 hours to 1 week, and in the interval after 6 weeks laparoscopy is contraindicated immediately after the postpartum. Okay, laparoscopy is contraindicated after tubectomy and the interval is after 6 weeks that they can have the intercourse. Is non-hormonal contraceptive uses. Now we are going to see what is the drug of choice. If there is an irregular cycles, it may reduce, and mild endometriosis, irregular cycles in the sense abnormal uterine bleeding we can also say, and hysterism, acne, loss of fibroids, abnormal uterine bleeding, risk factor will be reduced for this endometrial, ovarian and colorectal cancer, but it increases breast cancer. Risk of hepatic adenoma, breast cancer and cervical cancer. Ovarian is different, cervical is different. Okay. Absolute contraindications for OCPs. Now we have to discuss in deep. Okay. Hope will be having a mnemonic. Now we are going to discuss. Banks have various schemes to provide home loans during May. Banks have various schemes to provide home loans during May. B for breast cancer, H for hypertension, uncontrolled hypertension, vaginal bleeding undiagnosed. If history of smoking greater than year of 35, then also we are not going to give this OCPs. Thromboembolism in the sense CVA, MI, pulmonary embolism also we cannot prescribe. Pregnancy and postpartum cardiomyopathy we are not going to give. Hyperlipidemia, liver disease, diabetes with vasculopathy and migraine with ARA, we are not going to give this OCPs. Just remember the points, that is more than enough. Okay. Yes. Coming on to the missed OCP guidelines. Okay. We are administering this OCPs for the woman. Somehow if they missed, what they are going to do? As a nurse, what we are going to do the counseling. So here you can expect a question. So if one or two pills are missed, take as soon as continuously. Normally you have to take, no backup is needed. 1 or 2 pills is missed, no issues, you can take the pill as soon as possible, then you can continue the cycle daily. If more than 3 pills are missed in the first and second week, take the pills as soon as possible, continue, and there should be a backup for 7 days. Emergency contraception if intercourse is past 72 hours. We have to give this progesterone, that is levonorgestrel progesterone pills only we have to give. Okay. If more than third week, if the second and third week is different, if 3 pills is missed in the third week, then skip placebo pills, start a new pack. After active pills, backup should be there for 7 days. Okay, have you understood? 1 to 2 pills is missed, no issues. If more than 3 pills is missed in the first or second week, then we should take pills as soon as possible. Consider emergency contraceptive pills as soon as possible. if there is an unprotected sexual intercourse. If more than 3 pills is missed for in the third week, then we have to skip the tablets, that is the pack of the tablet. Then we have to start a new pack after the active pills. Active pills we have to take, right? Today we am going to take the import, the missed pills has to be discarded. Then we have to start a new pack after the active pills. Then there should be a backup for 7 days. Okay, these are missed pills guidelines you should note. Coming on to this hysteroscopic tubal ligation, it is a mechanism of action is the inflammatory fibrosis of the fallopian tube. Okay, what is actually doing tubal ligation we are going to do with the help of this hysteroscopic thing. Hysteroscopy we are going to do this tubal ligation. Okay, it is a not effective immediately. Use backup contraceptions for 3 months. Confirm bilateral blockage by HSD at 3 months. Again we are going to do this HSD at the level of 3 months. After 3 months, then we are going to see whether bilaterally it is blocked or not. Okay, so till now we have discussed about the contraceptive methods of temporary. Now we are going to discuss about the permanent contraceptive method, that is tubal ligation for female sterilization. What's the definition? It is the permanent contraceptive method for female. With the help of tubals we are blocking it disruption to prevent the fertilization. Okay, to prevent fertilization we are going to do. And types of tubal ligation is there. Postpartum sterilization within 24 hours or to 7th day of after delivery, that is postpartum sterilization, done via mini laparotomy. Okay, interval sterilization is equal to 6 weeks of delivery or after 6 weeks post delivery we are going to do, that is interval tubal ligation, done when uterus has returned to normal size. Okay, post abortal, following abortion we are going to do with combined with maternal termination of pregnancy. Concurrent, done during C-section or abdominal surgery, convenient when abdomen is already opened. Okay, after LSES we are going to do, we are having this 3, yes, postpartum, interval, post abortal is thing, and concurrent only when C-section we are going to do this tubal ligation. Is it clear? Yes. So postpartum within 24 hours or 7 days, interval after 6 weeks, post abortal is after abortion, concurrent after LSES. Okay, yes. Coming on to the techniques of tubal ligation. So we are having Pomeroy's method, where mid you can see is tied and exists. This is consider this as a fallopian tube. So here we are making a loop is created. Okay, the loop is created where the loop is tied and cutted. That's what they are doing, used in postpartum via mini lab. Okay, Parkland, it is a segmental excision without loop formation. Only the segment, consider this is the fallopian tube. Only the particular part is cutted and exited, that is loop formation, and it is exited. Only tying the knot is Pomeroy's. Parkland is something refers to interval sterilization where the loop is formed without segmental excision, without loop formation. The segment is exited. Okay. What is 𝐦𝐨𝐫𝐞? It is a subserosal tunnel with excised segment. It is low failure, not commonly used in India. So only you just remember subserosal tunnel with excised segment, then we can say 𝐦𝐨𝐫𝐞. Coming to 𝐦𝐬𝐴, it is the proximal stump buried in endometrium. The proximal stump is buried. It is permanent sterilization where it cannot be reversed. But this pompeilosis can be reversed. Okay, it is reversible. Fimbriectomy, it is an excision of this fimbrial end where the fimbriae is there, right? Fimbriae is ectomy. We have removed. It is a rare condition. Laparoscopic clips, fichet, rings we are going to use, that is fallope ring and electrocautery. It is not done in immediate postpartum, that is contraindicated in immediate postpartum. These two, that is clips, rings, electrocautery. So it is contraindicated in postpartum. Coming on to this histoscopy, where ensure device placed via histoscope requires 3 months plus HSD for confirmation. Okay, these are the techniques used in tubal ligation, where pompeilosis, Parkland, 𝐦𝐨𝐬𝐷 is not used. Okay, eye-wearing and fimbriectomy, laparoscopic and histoscopic. Okay, these are the things you should note. Coming on to this contraindication, where it is very important. If there is active pelvic inflammatory disease or reproductive tract infection, then we are not going to do this tubal ligation. Undiagnosed abdomen pain, any history of coagulopathy like DIC, pulmonary embolism, then if the woman is not fit for surgery, then we are not going to implement this tubal ligation. And no informed consent is fine. And advantages, it is highly effective, the failure rate is less than 1%. And one time procedure, we are not going to change 10 years once or 5 years once or not. We are not instructing the mother to daily take pills or anything, woman to take pills or anything. One time procedure and no hormonal side effects, less side effects is there, so that we are preferring this permanent sterilization. Disadvantages is always irreversible. Surgical anesthesia risk is there. Regret in young and nulliparous women. Failure of tubal ligation, where it can cause tubal, that is ectopic pregnancy, is the most common complication of failures occurs. Most common site of failure is always isthmus, where the isthmus is right. Okay. Vasectomy. Till now we have seen the tubal ligation for female sterilization we have seen. Now we are going to discuss about vasectomy, where male sterilization. What male sterilization? Okay, it is easy where the vas difference is cut. So only the vas difference is cut. Okay, the vas difference of the both the testes we are going to cut. It is also sometimes reversible. Okay, it is a permanent method of male contraception that involves ligation and excision of a segment of vas difference to prevent sperm from being ejaculated. Okay, sperm ejection is controlled, it is stopped with the help of this vasectomy. Types of vasectomy we are having, that is conventional vasectomy, where no scalpel vasectomy, NSV. This is another one type, where this conventional vasectomy, small incision is made in the scrotum to access vas difference and segment is ligated and removed. Coming on to this no scalpel vasectomy, vas is delivered through a tiny puncture without incision. Okay, preferred method for this National Family Planning Program, less pain, bleeding and infection. So this, which method is involved in National Family Program? This NSV, National Family Planning Program. This NSP. No scalpel vasectomy, where tiny puncture without incision we are going to do, and preferred method which is used, and it is having less pain, bleeding and infection. Okay, without incision the vas difference is cut. Okay, yes. Coming on to the procedure details. It is performed under local anesthesia, yes. Small segment 1 to 2 centimeter, both vas difference is ligated and removed. It has no effect on testosterone production, libido, secondary sexual characteristic, ejaculation, volume mostly from the seminal vesicle and prostate. So volume, only the sperm ejection we are controlling here. No hormonal thing is going to regulate. No secondary sexual characteristics it is going to alter. Anything it is not going to do anything. Only thing it is, we are not going to involve the sperm to ejaculate. Only we are stopping the sperm to ejaculate. Okay. Yes. Post vasectomy, after vasectomy, what we are going to do? That is the emergency, that is the important thing, sorry, where you can get MCQs. Okay. Not immediately effective. Backup contraception needed for 3 months. Okay. Almost 20 ejaculations. So we have to instruct the male person who have undergone this vasectomy, instruct them to use this barrier method like condoms. We can instruct them to use condoms, okay, during the intercourse. Ask them for 3 months to use. That is the window. We will say 90 days or 20 ejaculations. Okay. Semen analysis is required at 3rd month to confirm azoospermia, absence of sperm. Okay. Semen is there, only sperm should not be there. Okay. Until then, use condoms or other contraceptive methods. Okay. Yes. Coming on to the advantage, it is not an inpatient procedure, it is an outpatient procedure. No hormonal effect. It is the permanent and cost effective, where NSV has quicker recovery, because it is a non-invasive, right? It is only the tiny puncture we are going to do. Without incision, tiny puncture we are going to do, where vas deliver is cut. Okay. This. Coming on to this advantages, complications, where hematoma infection, but it is a rare, where granulomas due to sperm leakage, failure if recanalization occurs, late failure, and psychological impact, libido usually unaffected, but counseling is crucial. Some male will have like they will feel that I am not a male. The maleness they won't feel. So those they will have, the libido will be affected. So these things should be counseled, and we should improve their psychological aspect also. As a nurse, we have to do this. Okay. Coming on to this contraindications, scrotal infections, if epididymis, orchiditis, that is inflammation of the testis is there, testicles, then we are not going to implement this procedure. Undistended testis, relatively we are not going to do. And lack of informed consent and desire for future fertility, then we are not going to involve them in this permanent contraceptive method, that is vasectomy. Okay. Hope is it clear? Now we are going to discuss some of the Norcet oriented one-liners, where the comprises of these things. Just we'll have a quick summary. This centimiron, that is a non-hormonal, which we can call shell. Now we have discussed about the contraception. Now we are going to discuss some important one-liners which is related to Norcet. This centiroman, it is nothing but this ormeloxifene 30 mg tablet. It is also a non-hormonal contraceptive pill which makes the endometrium out of phase. Okay. This is one of the important thing. And most effective emergency contraceptive is always copper T380A. Hormonal method, then we can do this ulipristal acetate. And IUCD is the less bleeding, that is Mirena, abnormal uterine bleeding. If there are any PID, then we are going to give this Mirena. OCP safest in seizure disorders, that is DMPA, which reduces the seizure activity. OCP risk in postpartum, if it is less than 21 days, absolute contraindication. It is if it is contraindicated to prevent thrombosis. Thrombosis risk is high. Common infection with OCP is always candidiasis. IUCD insertion causes pelvic inflammatory disease. Most common is actinomyces. Missed thread with IUCD, USD first, followed by hysteroscopy if it is embedded. Post DMPA, 4 weeks delay, rule out pregnancy, backup for 7 days. Post DMPA, 4 weeks delay. If we are delayed for 4 weeks, we have to rule out pregnancy and backup for 7 days we have to keep. Okay, till now we have discussed some of the important points. Now we are going to discuss some MCQs. Okay, yes. A 27-year-old woman visits the clinic requesting contraception. She is known case of Wilson disease. Which of the following contraceptive methods is contraindicated in her? So 27-year-old, she is known case of Wilson disease. So Wilson disease, you all know it is very easy now. Already I have stressed the point. Copper T380A, which is having a copper, so it induces thing. Okay, copper T380A is the answer. So copper T IUCDs are contraindicated in Wilson disease, though copper metabolism abnormalities is already happening in that. So we are not going to give this copper 380A. Okay, this Centcoman, it is a non-hormonal contraceptive pill. Okay, non-hormonal. Here it is having a drug called ormifloxacin. Okay, ormifloxacin. Coming on to the next question. Which of the following emergency contraceptive is considered the most effective overall in preventing pregnancy? In preventing pregnancy, which is the most effective? They are asking. Emergency contraceptives. Levonorgestrel, okay, ulipristal, mifepristone, copper T, IUCD. They are not telling about the hormones here. Okay, they are telling about non-hormonal method like devices they are asking. So it is always copper T. Already I have stressed the point. So hormonal method, then you can choose this ulipristal, but copper T IUCD is the effective contraception in non-hormonal method. Okay, yes. Okay, copper T 380A is having 10 years of duration. Okay, copper T is most effective emergency contraceptive when inserted within 5 days of unprotected intercourse. It is more, this is one of the important point you should use. What is the within duration? How much time we are going to take before the insertion? Within 5 days of unprotected intercourse, we have to insert this copper T. Okay? Yes. So next question. Which one of the following is non-hormonal method of contraception that works by making endometrium out of phase? Now I have discussed this thing in golden points. Now it's easy, right? That is, cetrazine is not, mifepristone is not considered as the emergency contraception, but this one is considered as which endometrial out of phase it is doing. Okay, this Shenkoman, that is Shaili, it is a non-hormonal contraception that inhibits implantation by altering endometrial receptivity. Okay, yes. Coming on to the next question. How woman using OCPs reports new onset of headache like visual aura. What is the next step of management? Continue OCP, add iron supplements, discontinue OCP immediately, switch to combined injectable contraceptive pills. It is always we should discontinue OCP immediately. Very easy question, right? Yes. We should not make a confusion here. Add iron supplements, does not all. We should. It is because this is a side effect of this OCPs. So patient is having some sort of issues with the drug. So we should immediately stop the drug. Okay, migraine with aura is an absolute contraindication to oral contraceptive pill to use increase of risk of stroke where thrombosis, um, cardiovascular risk also high. So we should discontinue the OCP immediately. Okay, migraine. And what are the other relative contraindications? What I have discussed: liver disease, smoking, and any history of coagulopathy, undiagnosed vaginal bleeding, We should not use OCPs. Okay. Yes. Now, next question. Which of the following is true regarding Mirena? It acts by preventing fertilization. It is preferred emergency contraceptives. It reduces menstrual blood loss. It is useful in abnormal uterine bleeding. It is contraindicated in women with history of ectopic pregnancy. Which is true they are asking. So it is used in abnormal uterine bleeding. So this will be your answer. Mirena. Okay. It reduces menstrual blood loss and is useful in abnormal uterine bleeding. But what is the rationale? Easy. Mirena thins the endometrium and reduces the menstrual blood loss. Okay. It is not used for emergency contraception, and progesterone only pills also we are not using, and misoprostol also we are not going to use as emergency contraceptive pills. Okay. Next question. A postpartum woman exclusively breastfeeding a child wants contraception. She delivered 2 weeks ago. Okay. Which of the following is most appropriate? OCP combined, DMPA, IUCD after 6 weeks, tubal ligation via laparoscopy. Always, we are not going to use OCPs after 6 weeks. Okay. DMPA is the answer. Where after 4 weeks of postpartum breastfeeding woman, but OCP is contraindicated less than 21 days because it increases thrombosis risk. Okay. Only DMPA we are going to use. DMPA Antra greater than 4 weeks. Okay. Yes. Next question. Which of the following OCP related cancer is increased in perimenopausal females long-term use of OCP? Where that is always breast cancer and cervical cancer. It will reduce the risk of endometrial, ovarian and colorectal cancer, but it increases the risk of breast cancer and cervical cancer. Okay. Yes. OCPs increase the risk of breast cancer in older women but reduce the risk of ovarian, endometrial and colorectal cancers. Okay. Yes. Next question. A patient who missed 3 OCP in third week of her cycle should be advised for. Missed 3 OCPs in a third week. Then we have to take missed pills and continue the same pack? No, we are not going to do. Discontinue pack and restart after withdrawal bleeding? No. Take missed pill, skip non-hormonal pill, start a new pack. Use emergency contraception, restart after 7 days. No, this also we are not going to do. We have to take the missed pills, skip the non-hormonal pills and start a new pack and have a backup for 7 days. This is used if they missed 2 or 3 pills in second and third week, then we are going to use as emergency contraceptive, take the missed pills also and have a backup for 7 days, not restart. We will be having a backup for 7 days. Emergency contraception within 72 hours after the unprotected cycle, that is if they missed in second and third week. Okay, this is the important thing you should note. Okay. Okay. Take missed pills, skip non-hormonal pills and start a new pack. As per the GO guidelines, after 3 missed pack, that is the missed pill in the third week, the new pack is started immediately without waiting for menses. Okay, without waiting for menses, we have to start the new pack. Coming on to the next question. So what is the mechanism of action of Ensure device using hysteroscopic sterilization? Insertion of this device already I told. It always mechanical tubal ligation occlusion? No. Hormonal suppression of ovulation is not going to do. It uses induction of fibrosis by inflammatory response. This is the answer. And addition of fallopian membrane is not going to do. Okay. Yes. Ensure causes inflammation of the fallopian tube leading to fibrosis and permanent tubal blockage. Considering if the fallopian tube is this, okay, the fallopian tube is this. If there is a layer inflammation, then there will be a tubal block. Okay, there won't be fertilization is not going to happen. Okay, that is the Ensure device is going to do through histoscopy. Okay, yes. Which of the following is not included in the list of contraceptives safe to start from day 1 postpartum? Okay, not included. It is included. Okay, progesterone only pills we are going to do, condoms also, but OCPs we are not going to give OCPs because it increases thrombosis. Risk is there, and especially in breastfeeding women. Okay, yes. Coming on to the next question. A 28-year-old woman undergoes postpartum tubal ligation 12 hours after a normal vaginal delivery. Okay. Which method is most commonly used in such cases? Parkland technique, Ivering techniques, Pomeroy technique, laparoscopic clip application. Okay. Undergoes postpartum tubal ligation 12 hours after a normal vaginal delivery. So within 24, 48, within 12 hours we are going to do. Which method is always Pomeroy's technique? Okay. It is a modified Pomeroy standard technique used in postpartum via millilaparotomy. Okay. Pomeroy's techniques. Coming on to the next question. A nurse is counseling a 35-year-old multifarious woman for interval of tubal sterilization. She is 8 weeks postpartum. What is the correct timing to perform this procedure? 8 weeks postpartum. Okay. Within 1 week postpartum, after 6 weeks postpartum, during menstruation, anytime after delivery. What they are asking, multifarious woman, interval tubal sterilization. Okay, it is done only after 6 weeks of postpartum. Interval, I have put the term, stress the term. Interval is done after 6 weeks of postpartum. Okay. Coming on to the next question. Which of the following techniques involves burying the proximal tubal stem into the myometrium to reduce failure? It is always Irving. Okay. Irving technique is the proximal stump is buried, reducing the chance of recanalization, and there is an ectopic pregnancy. Okay. Yes. Which of the following is contraindicated in immediate postpartum laparoscopic tubal ligation? Previous cesarean section, hemodynamically stable condition, less than 24 hours of postpartum, no known allergen to anesthesia. This is always within, if it is less than 24 hours of postpartum, we are not going to do this laparoscopic tubal ligation. Okay. So laparoscopic sterilization is contraindicated in immediate postpartum due to enlarged uterus and safety concerns. When the uterus becomes to the normal after 6 weeks, then we are going to do this postpartum laparoscopic tubal ligation. Okay, yes. Coming on to the next question. Which of the following is most common site of failure after tubal ligation? Fimbrial end, no. Ampullary segment, ischemic segment, uterine karma. It is always isthmic segment. Okay. Most failures occurs as isthmus due to incomplete tubal occlusion or recanalization. Okay. Yes. Next question. A man undergoes no scalpel vasectomy. Whether it is included in National Family Program or not, it is included in National Family Program. Okay. What is the correct advice regarding contraceptive post procedure. After the procedure, what we are going to do? Sterility is achieved immediately. Avoid intercourse for 6 weeks. Use contraception until semen analysis confirms 𝐦𝐨𝐫𝐞. Repeat vasectomy in 2 weeks. Okay. First, after semen analysis of 3 months, if it confirms 𝐸𝐴𝐵𝐷, then it is the correct procedure. Okay. Vasectomy is done perfectly. Okay. Yes. Use contraception until semen analysis confirms 𝐸𝐴𝐵𝐷. Vasectomy is not immediately effective. Semen analysis may still contain sperm up to 3 months. Okay. As the male person to use temporary contraceptive methods. Okay. Yes. Which of the following is true regarding non-scalpel vasectomy? Requires general anesthesia? No. Higher risk of hematoma than conventional method included in India's National Family Planning Program reduces testosterone level. It does not have anything, hormone regulation is not going to do, and secondly sexual characteristics is not going to interfere in anything. Risk of hematoma, but it's a rare condition. Requires general anesthesia? No. It is included in National Family Planning Program. Already I have stressed this point lot of times, so you just remember this. Okay. Yes. Then which of the following best explains why vasectomy does not affect libido or erectile function? So vasectomy decreases testosterone level? No. Sperm is essential for libido? No. Vas difference is unrelated to hormonal function. Okay. Ejaculation is completely prevented. Okay. They are explaining why does not affect libido or erectile function. Okay. Vas difference is unrelated to hormonal function. There is no hormonal function alteration is done. Okay. That's why this thing is happening. Okay. Yes. Vas difference is unrelated to hormonal function. Okay. Coming on to the next question. Which of the following is most appropriate method to confirm the success of vasectomy? Decreased ejaculatory volume, normal libido and erection, scrotal ultrasonography, semen analysis at 3 months. Okay, to confirm 𝐸𝐴𝐵𝐷. Okay, yes. Confirmation of vasectomy success is done via semen analysis showing 𝐸𝐴𝐵𝐷. Okay, 3 months. Which statement about vasectomy and tubectomy is false? Okay, I think it's easy. Tubectomy is surgically more complex than vasectomy. Yes. Vasectomy requires backup contraception post-procedure. Yes. Okay. Both methods are included in NFP. Yes. Tubectomy has the faster return of fertility than vasectomy. Now, here comes the question. Okay. Vasectomy has persistent sperm for months. It is not a faster return of fertility. Okay. But once azoospermia is confirmed, reversal is less likely. Tubectomy is generally considered more irreversible. More irreversible is this tubectomy. Okay. Yes. Fertility is not possible. Okay. Yes. Okay. Till now we have discussed some of the important points related to contraception and that related MCQs. Okay. Hope this class was helpful. Let me discuss some other topic in next video. Thank you.